Good afternoon, distinguished guests, speakers, ladies and gentlemen. Welcome back to the afternoon session of the 5th Thailand Elderly Health Service Forum 2025. I hope you all enjoy your lunch. My name is Pechada Wachara Wutpana. I will be your MC for today. Before we begin, please allow me to share a brief agenda. In this afternoon, we will have two sessions lined up. The first one is geriatric medicine, technology and innovation for future challenges. And the second one is dementia management for the elderly, technology and innovation. And without further ado, let us begin with the first session. In this session, we will explore how innovation and technology shape the future of geriatric medicine. And in this session will be moderated by Dr. Manita Gitti Lertwaragun from the Institute of Geriatric Medicine. And please join me in welcoming our moderator, please.
Thank you, Kun Pechada. And good morning, good afternoon, distinguished speakers, guests, and participants. It's my pleasure to welcome you all to this session on technology and innovation for the future challenge of geriatric society. My name is Manita Gitti Lertwaragun, or you may call me Give. I am geriatrician at Institute of Geriatric Medicine, and I'm honored to be your moderator for today's discussion. As we all know, the aging population is rapidly increasing worldwide, bringing both opportunities and challenges. In this session, we aim to explore how technology and innovation can address the unique needs of our aging society. From healthcare and mobility to social inclusion and beyond. We are privileged to have with us today a panel of esteemed experts who will share their insights, experiences, and visions for the future. At the end of presentation, I encourage everyone to actively participate, ask questions, and engage in what promising to be an enlightening and inspiring discussion. Without further ado, let us begin by introduce our speakers first. Dr. Wirasak Meung Phaisan, Chairman of Sirat Academic Center of Geriatric Medicine from Thailand. And next, Dr. Kok Kiatsen, Head of Department of Geriatric Medicine, Changi General Hospital from Singapore. And Dr. Taiji Ono, Director, Health Policy Concentration, National Graduate Institute for Policy Studies from Japan. Dr. Ono will stay with us on a live form. Let's give them a warm round of applause again. Okay, we will begin with Dr. Wirasak. Dr. Wirasak is a geriatrician with extensive qualification in neurology and preventive medicine from leading institutes including Oxford and Cambridge. Dr. Wirasak is a renowned expert in geriatric medicine, dementia, and cognitive disorder. Now, he will present on the cutting-edge technologies and innovations being developed in Thailand for the benefit of our aging population. We eagerly await your presentation. Please share your insights.
Thank you, Dr. Manita. Good afternoon, everyone. Distinguished audience, I'm very honored to have this opportunity to exchange the idea about technology and innovation for future challenges. I'm currently work at the Faculty of Medicine, Silat Hospital. And in Thailand, we have the aging tsunami in those who were born in 1963 to 1983. Last 2 years, they reached the age of 60. So at that time, every year we have more than 1 million births. So from the year 2023 and for the next 18 years, 20 years, we will have more than 1 million people who are in the age of older than 60. So we have the very sharp increasing number and proportion of older people. At the moment, the mean age is allowed 32 in men and women is allowed 80 years. And those who were older than 60 years allowed 21 to 22%, and older than 65 years allowed 14%. But in the next 20 years, next 15, 20 years, we will have more and more problems. The living status of Thai older people at the moment, living with others, with their family, allowed 2/3, and living with the spouse only, around 23%, and living alone is allowed 13%. So we will have more and more problems about caregiver. Challenge of aging society everywhere in the world because of the population structure change, rapid growth of proportion of older people. So the consequence to the health in terms of the chronic disease, disability, dementia, frailty, that will be more and more increasing. We try to have innovation and technology, but the problems, especially in country with limited digital literacy, is about how to use it, how to get the access to the innovation technology, how to make it in our routine practice. So usually it is a model for care, but not in the routine practice. The home and environment, there are several projects to try to design for the age, for the environment for age and disability friendly environment. But one of the problems is about the budget and about do they have the foreseeing in the future that they are going to be owned in that environment. So economics is the big issue at the moment worldwide, and the social problems about the smallest family size and the lack of caregiver. So the main purpose of technology and innovation for older people, the first one is to, if you try to see in every technology and innovation, the first one is to detect early detection or predict the disease progression or predict to make it more precise in the clinical diagnosis and treatment. The second one is about the mobility and dependency for disease support. For example, exoskeleton or advanced wheelchair or something. And for other disability, for example, for those with swallowing problems, for hearing and vision, for safety and monitoring, especially for falls, for wandering in those with dementia, and for the cognitive, maybe to monitoring, detection and treatment, and for the social support, and for make the service and everyday life more easily. This is the main, I think the main purpose of the technology and innovation. In terms of dementia, the three specific the first one is to screen and early detection. This is the longest standing use of technology in dementia. Several decades that there are several cognitive assessments to screen for dementia and for the accurate diagnosis. And for specific treatment, both in terms of pharmacologic treatment and non-pharmacologic, and for general care to make the patients living at home with safety and make them able to perform their everyday function and leisure and activities and make the caregiver take care of the patients more easily. The project that one of the projects that I currently run is to do the online screening platform. So everyone can do the online screening for their health status, not just for dementia, for frail, for false list, for muscle health, for cognitive, for mood problems about all the people. Then they will have initial insight that they might have the list. And then the second step is the face-to-face evaluation, in-depth evaluation to make them to check for further assessment. For example, that you see on that one is the cognitive screening online. I think at the moment we have several cognitive screening. The limitation of cognitive screening is, especially for online, is about if we use for example, clock drawing, or there might be limitation in reading, hearing, and in some activities that they cannot do because of disability related to dementia. So we try to develop the screening test that can easily use with those people who have hearing problems, or those people who have cannot use the pencil, cannot use the pens, so they can do the screening, and which can provide a very accurate form. The AI intelligence for dementia diagnosis, there are maybe 5 main stems. The first one is to monitor speech. Speech pattern can determine the cognitive status of the list of dementia, and do they have dementia at the moment. And the second one is about the analysis of medical image, the brain volume, or by using the AI machine. And the third one is visual indicator. I think I saw one booth in this meeting that there is a company. This is to check the eye movement to predict the risk of cognitive impairment. Not just in the past, we used the retina scan to see the amyloid burden that correlated with the brain. But at the moment, they check the eye movement to correlate with cognitive function. And the genetic risk and blood biomarkers, which be more and more interesting in the future. So they try to, all of the things are try to diagnose dementia at the preclinical diagnosis by using genetic markers and neuroimaging, maybe amyloid PET scan, tau PET scan, or advanced neuroimaging technique. And by using CSF biomarker, at the moment, I think CSF biomarker is less common because it's quite invasive. So we try to use the blood biomarker instead of CSF biomarker. So the second thing is about this for the treatment. I think for the treatment of dementia, there are several new medications, one of which is the disease-modifying therapies to target amyloid, to reduce the amyloid burden in the brain. But this one is the aim is for people with amyloid positive, mild cognitive impairment, just have some impairment of the cognition or early dementia, not advanced dementia, or not for anyone who do not have the amyloid in the brain. So this is the problem is about the accessibility and the cost of the treatment. I think this is the problem. And also the home visit, we have the project because when we do the home visit for people living at home in the long-term care, usually there might be several people to visit one patient at home, and they do not have the joint information. For example, nurse doctors and the information might not link to the hospital as well. So we have the project try to harmonize the visit from every multidisciplinary team to have the same visit, and we use the same platform so the nurse can see the doctor or the physical therapist, what is their goals, what do they prescribe already for the patients. So this is the things that we try to harmonize the system. And for the last one is about the general care, dementia-friendly environment in terms of make the daylight, illumination, color, sound, smell, or use the symbol, nature, or care climate, or animal, or pet therapy. I think pet therapy is now, there might be some nursing home in Thailand using pet therapy for dementia as well. But this is just in the beginning process, I think, not practiced everywhere. Then innovation might be in terms of the service provided, not for the digitalization or the technology only. At Silat, at my Faculty of Medicine, we have the project for the safe home and environment adaptation for older people, especially for people with disabilities. So we have to go to check their risk in their home environment, and then do the universal design and home adaptation and create a project with the budget. The problem is about the budget and the support from those many organizations involved. One of the problems in Thailand, we have limited number of specialists taking care of dementia. Because dementia, usually we think that they will be seen by neurologists, psychiatrists, or geriatricians. But in the country, the whole country, we have neurologists allow 800, psychiatrists allow 400, and geriatricians allow 80 for the whole countries. But many of them might not be interested in dementia. Some psychiatrists, they might not be interested in dementia, not everyone, and also the neurologists. So we try to improve the training for family medicine. Throughout the country, we have more than 8,000 family medicine doctors. Those who finish the full course training allow 1,000, but some people got the short training in family medicine. So the development of the platform for electronic e-online training and e-online platform for geriatric medicine and for dementia. And also, I think the Department of Medical Service also have more than, I think, 8 or 9 years of the training for general practitioner and family medicine for the course to provide them with geriatric medicine concept. For 8 or 9 years that I get involved in this project, maybe I think almost 1,000 people get trained in the short course of this course. There will be both the lectures and the workshop and the online platform. And at the moment, we focus, one of the problems is about people who live in nursing home. That they have caregiver in the nursing home. In the past, more than 10 years, that I trained family caregiver to take care of older people with dementia. But in the last 2 years, we shift the focus to caregiver in the nursing home because they have the problems to take care of their clients with dementia, with behavioral problems in the nursing home. So we organized the short course training for the nursing home project. And in these 3 days, this morning, I also have the project with the Ministry of Social Development and to organize the training for nursing care staff in the centers. For example, Ban Ban Care is also one of the centers throughout the country. And for the Department of Medical Service, they also have the clinical practice guideline for dementia care model and self-care screening and diagnosis, and to develop dementia care manager and comprehensive care model. Several models in the care. One interesting is the special committee or jury model, where the doctors in the rural cities, they are not familiar with the diagnosis of dementia and the care of dementia. So we have the webinar, and we ask the specialists to join to help the family doctors to make diagnosis and care plan together. And one is the project about intrinsic capacity with the WHO ICO in the community. There are six domains: and visual, hearing, cognitive, psychological, locomotor, and vitality, which is the nutrition in this model. We try to do the throughout the countries, there are the screening in 3 steps in 9 domains as well to try to cover, but there still might be some of the problem in linking the service together. So we try to organize the care process, start from the screening, the self-care, and the referral, and the personal care plan with the stakeholder in the rural cities. This is, for example, in terms of the ICOP Living Lab in the communities. And at the moment, we try to expand to cover more than, in the past we cover one province, but at the moment we try to expand to cover 8 provinces with the project. And for the device, there are several devices that might be used. One is the wearable physical sensor. I think this one is the most familiar. But we also have wearable chemical sensor and non-wearable sensor or multi-variable. The wearable sensor is something to measure the vital sign, the heart rate, the EKG, and also the body temp, oxygen sat, and blood pressure, or mobility and activity related. For example, step count, and to detect fall events or something, and for the remote monitoring. But I think the wearable chemical sensor, which is now is being used, is one of the most common is the glucose monitoring. So might be the sensor attached to the skin, and then to monitor their blood pressure without the POCT glucose. And so I think, but there are also other chemical composition as well that is monitored, for example, sweat, tear, saliva, and interstitial fluid. This is the lab on the skin. So a variety of metabolites and electrolytes are monitored. And the hybrid is something between physical and chemical sensor. And for the non-wearable sensor, for example, the detector, the sensor, something in the house, I think Dr. Sen might cover about this aspect. So I think in the future, maybe we might have a lot of physical sensor, chemical sensor, non-wearable sensor, but I'm not sure that all the people, they really want to have this, or they want to have more tangible contact and more community, more family related. But unfortunately, we don't have family members and the support in every family. So I think there might be the mixture between the high technology and the basic concept. So I will conclude about the proportion of older people with limited caregiver in the future, and trend of healthcare and innovation are increasing. The problem, one of the major problem is might not be affordable and might not be accessible for everyone, and everyone might not accept the technology and innovation as well. So, and also the first step is to make it accurate to be safe and accurate to prove the effectiveness. So this is the major things that should be concerned. Thank you.
Thank you, Dr. Virsak, for that enlightening presentation. Your insight on this topic have truly provided us the valuable perspective to reflect on. Now, moving on, we're excited to welcome our next speaker, Dr. Go Kiat Sun, a distinguished geriatrician with a focus on orthogeriatric, osteoporosis, and fall prevention. He graduated from the National University of Singapore School of Medicine and received his specialist accreditation in geriatric medicine. Dr. Go is also a dedicated educator and researcher. Research interest you can see in the publication list. Dr. Go will be sharing his expertise on technology and innovation in Singapore. Please, Dr. Go, share your insights.
Hi, good afternoon. So thanks to Prof. Virsak for the very enriching lecture. I'm Kiat Sun from the Department of Geriatric Medicine in Changi Hospital, Singapore. So thanks for inviting me to share Singapore's perspective to aging as well as our policy. And I'll also be talking about tech and innovation. I'm sure many of the themes will resonate with us today. So this is an overview of my talk today. I'll talk about the aging landscape and healthcare policy in Singapore. I will then go through some of the innovative geriatric care models that we have in our hospital. So this would include an age-friendly hospital, a frailty-friendly hospital, and I'll also share a little bit about hip fracture program. After that, I will go through some research publications on falls, frailty, and sarcopenia technology. So first, I'll start with aging demographics of Singapore. This is our Singapore Ministry of Health healthcare philosophy. So number one, we want everyone to live long, but more importantly, to live well, not just to live long. We want to provide appropriate care, quality care, as well as the right site of care. So for example, not every aging condition must be managed in the specialist clinic or in the acute hospital. It must be very broad-based and into the community. We also want sustainability of resources, cost-effective care, and that no one should be left out, especially those of the lower socioeconomic status. So in Singapore, we have 3 healthcare clusters. As you can see on the right side, my hospital is Changi General Hospital, and we cater to the eastern population of Singapore. We are part of the Sing Health group. And we serve a very, very big proportion of elderly residents in the east of Singapore. We also serve the Changi Airport in Singapore, which is very well renowned. So we get a lot of hip fractures from the airport as well. So you can see this is actually the primary public healthcare versus the private healthcare landscape in Singapore. Those that are in blue are actually the public healthcare organizations, and the private healthcare are those that you see there in orange. I want to direct your focus to the primary care setting, and you can see that in Singapore, primary care, the largest proportion is actually run by general practitioners, and that is under the private. So we really need to engage them in terms of developing shared models of care as well as geri services. These are the very important statistics that we're dealing with in Singapore. We will become a super aged society next year. So 21% of the population will be above 65 next year. 1 in 4 will be elderly by the age of 2030. More will be living alone. And if they are admitted to hospital, they are more likely to stay much longer. We often call this the silver tsunami. But maybe we should call it something else, like aging challenge or the paradise of aging, because maybe we shouldn't call it a tsunami in such a negative way. But we do know that this is actually very commonly mentioned in publications and journals. Also introducing the concept of health-adjusted life expectancy, not just living long enough, but also to live with a healthy life. And in Singapore, we have a very established, very renowned world-class healthcare system, but this is not enough. We must innovate and respond to the aging challenge. Singapore is already 83 years for life expectancy, but we are only 73 for healthy life expectancy. So there is a big gap of 10 years that people are in poor health, they are disabled, they can't do their activities of daily living. And I point you to the numbers on the right side. So this is what our Minister of Health has tasked us in Singapore to try to achieve. These are just a dream that if our life expectancy can be 90, then hopefully our healthy life expectancy can be 85 or higher. We try to narrow that gap. Now, so our Ministry of Health has done much to innovate and to transform the healthcare sector to deal with this aging population. So what you see here are actually policies that are a result of all these transformation process. So what we have rolled out since 2023 is the Healthy SG policy as well as the Age Well SG policy. So these are being implemented in various phases. The Healthy SG policy wants to activate the family physicians to be involved. They want to grow community partnerships and enroll every member of the population into a Healthy SG team for long-term management. So this is an overview of the institutions that we have in Sing Health, and we can see in the center, there is the Healthier SG team. It consists of the primary care doctor, the community nurse, the well-being coordinator, as well as the community partners. The aim is that everyone gets enrolled under a primary care doctor. The geriatric services will then wrap around this core Healthier SG team to provide the additional support that these elderly patients need in the community. The Healthier SG team will also manage transitions from hospital to home, transitions from home, and link them up to community resources. So in the east side where we cover, there are 32 Healthy SG teams, and they are sited at 119 community health posts. So this is where health screening is done. There can be delivery of basic geriatric care. We do home safety assessments, connected with community services as well as social care support. And a crucial part of this is also chronic disease management. As for Age Well SG, which targets the older population, we have developed active aging centers. So this would create a lot of activities which include exercise and cognitive stimulation for the elderly. We also want to enhance home-based care to support even the most frail patients at home to age in place so that they don't end up prematurely in a nursing home. And Age Well SG also includes the infrastructure development, the elderly-friendly infrastructure, the living environment that we have to encourage mobility and patients to be going out of their house and not be staying at home. And linked to Age Well SG are some of these big projects that we have in Singapore. So I would like to highlight the Kampong Admiralty. Since 2017, there are 100 elderly flats where the elderly live in. These are very small studio apartments with enhanced facilities inside. This kampong is like a village, so it's also linked to retail facilities, commercial facilities. There is a health center, there's a childcare center, everything is integrated together. So this is an integrated concept of living whereby the elderly can feel that they are part of the wider community. In Singapore, we also have community care apartments. This is a very new concept. This improves on the current studio flats with added support and infrastructure. I mean, ultimately, we want our elderly to age in place, and that is a very important concept to embrace. So in many ways, we have been forced by circumstances to improve and to innovate on our care models in Singapore. And I must say that going through the COVID pandemic, this has accelerated the technological innovation process. It has forced us to adopt telemedicine as a very wide-scale, mainstream option of care. In Sing Health, we have also rolled out the Health Buddy app. So this is an app that the individual patients can use. It provides personalized health information. It gives them resources. There are also special care modules for geriatric conditions. The patients can use this app to book appointments, change appointments. They can register for their clinic appointments. They can check their medication list. They can access their blood test results online. So these are some of the very recent technological advances that we've rolled out. I'll now move on to innovations in geriatric care models. So what does innovation mean? It means actually to develop something new, to create and then to implement new ideas, new concepts, new technology, new processes and new services. So I'll go on to share at hospital level innovation and then some smaller projects that we have. So when geriatric medicine started about 3 decades ago in Singapore, there were very few geriatricians, and our model of care was that we just operated in a single geriatric acute care for elders unit, and there was a small multidisciplinary team. But we have had to grow much more than this. Having just an ACE unit in the hospital is not enough. I'll move on to share some of our hospital-wide initiatives. So in our hospital, the geriatricians no longer just run the acute care ward. So the acute care geriatric wards, we have about 200 over beds, but the hospital has more than 1,000 beds. So we have to link up with so many other departments. As you can see here, we now have outreach, liaison, co-management services in the emergency department, in the short stay unit of the emergency department, the acute medical unit. We also have reached out to the subacute wards, the rehab wards in the hospital. We have gone into the community, and community is also a huge area. We have inputs into the hospital at home, hospital to home, transitional care, as well as geriatric day hospital. So all these services that we have grown throughout our hospital actually leverage on the 4Ms framework for an age-friendly healthcare system. What matters to the patient, the mobility of the patient, the medications of the patient, as well as the mental health of the patient. So this is the tiered framework that we use to run, to make sure that geriatric care is enforced throughout the hospital. So at the bottom, you can see that there's a standardized framework for standardized assessments of elderly. So this builds on our niche nursing program. We have achieved a niche exemplar status. And this means that all our nurses already have a fundamental knowledge and competency in geriatric care. The second level is that we also have hospital-wide initiatives that are geriatric, created. We are leading these initiatives. For example, we have a delirium outreach team. We also have a frailty protocol, which I will share, and we also have a geriatric emergency department service. And at the top, that's where we manage our acute wards and the very, very critical services whereby we need geriatric co-management in orthopedics as well as in surgery. Shall move on to touch a bit about frailty. So frailty is one of the emerging geriatric syndromes. It is very, very common. We all need to know about frailty. It is a state whereby there's compromised physiologic reserves and the patients are vulnerable to all sorts of adverse outcomes. We cannot just focus on treating the chronic disease, the individual acute illness, but we need to think of the patient as a whole, and I think that's how frailty comes in, that we are unable to see the patient as a whole and what matters to this patient. So our Ministry of Health has released a national frailty strategy, which includes 3 steps of case finding, assessment, and management. And so our healthcare system must follow this. We must evolve to innovate care for frailty, and more importantly, to prevent those in the earlier stages of frailty from becoming more and more frail. And what do we do in our hospital? I would like to introduce you to the the electronic system whereby we have incorporated the hospital frailty risk score. We do the HFRS as an electronic measure of frailty. So this is assembled from 109 ICD codes. They are then segregated into risk categories, low, medium, and high risk. We complement this with the clinical frailty scale, which is in a lot of guidelines on frailty already. So we use this dual approach of the electronic system generating the hospital frailty scale, as well as CFS, which is scored by nurses. So we have already implemented this in many departments in the hospital, such as in the emergency department, the short stay unit, the acute medical unit, heart failure pathway, as well as in the surgical department. So we must be able to recognize frailty. We must be able to stage it correctly, because if we stage it correctly, we can then develop the relevant interventions for it. So for example, for those who are robust, those who are not frail yet, they are CFS 1, 2, and 3, we need to make sure that they live a healthy lifestyle, manage their chronic diseases well, make sure that they have a good nutrition and resistance training. On the far end of the spectrum, the patients have severe frailty. And in such cases, we need to think about advanced care planning. We need to think of palliative care. We need to think about what matters to the patient instead of seeing 10 specialists and also having so many medications given to them for each individual condition. By then, of course, we also know that their functional status would have declined. So we need to look at the big picture here. This is our hospital frailty protocol, which we are in the midst of rolling out to all the non-geriatric wards in the hospital. So as part of this, we incorporate the HFRS and the CFS screening. And thereafter, we used our interdisciplinary team to manage frailty. This also relieves the burden of care on the primary team itself to manage frailty, because we have the shared care whereby all the interdisciplinary professionals come in to manage it together. Frailty also extends to the community. So in the active aging centers, there is also frailty screening going by clinical frailty score. And in addition to that, social frailty is an important component of overall frailty as well. So you can see here that in our active aging centers, where our seniors go to have activities, there is also the screening for social frailty and the subsequent interventions that are needed. The next program that I want to share with you is the value-driven care hip fracture program. So as we know, hip fracture is one of the very serious fragility fractures to have. They come in often at a very old age. By then, they would have a lot of comorbidities. They will be very frail, and they have very poor outcomes, even if they go for surgery. So in our program, based on best practice evidence and guidelines across the world, we have devised this whole protocol whereby the patient is taken care of the moment they come to emergency department. The geriatrician and the geriatric case manager in charge of the hip fracture program will guide the patient throughout their journey until discharge. We also follow up the patients up to 1 year. Incorporated into this program, we also have the fracture liaison service for osteoporosis. We also have telehealth monitoring over 1 year. So why we call it value care? Because value is an important concept. It is about economics of healthcare. We need to achieve high value of care for patients, which means deliver very high quality, but also cost-effective care, because there's no point in giving high quality, but then the cost is also very, very, very high. So you can see this is the formula for calculating value. And how do we achieve high value? By harnessing all the capabilities of the interdisciplinary team in care of the hip fracture patient, and also by making sure that we have good quality care. So these are just some of the clinical indicators of our SingHealth Hip Fracture Value Care Program, whereby we aim for very stringent KPIs, key process indicators, such as early surgery within 48 hours, minimal medical complications, lower the readmission rate, early discharge, lower mortality rates, reduced blood transfusion rates. So we impose these very strict conditions upon ourselves as part of a regular audit and quality improvement process, so that we can deliver the best quality care and value care. So this program actually has won an award at a national level in 2023. So now I'll move on to a few slides on technology. So the guidelines, if you read on falls, they are everywhere. You know, so this is from Age and Aging, from the British Geriatric Society. These are the World Falls Guidelines. We know that falls is a major geriatric syndrome, and if you fall, an elderly patient falls, they are more likely to fall again many, many, many times, It is also very closely linked to frailty and sarcopenia. The management of falls is multifactorial. So it's important to harness technology in fall prevention. This would include using analytics with big data, video monitoring, alarm technology, wearable sensors. Some of these Prof has previously already explained. And there are many, many publications out there, for instance this one, that summarizes the entire spectrum of tech-based applications in various settings for falls prevention. So even the simple time up and go test can be instrumented. You can make the patient wear a sensor, and this will give more objective measurements that are less prone to error by the human measurement. In one of the falls clinics in Singapore, we also used the PPA. Stephen Lord from Australia devised the PPA assessment, and we also harness technology such as sensors and dynamometers to measure these 5 components of the physiological assessment in falls. Gait measurements, they can also be subject to various technological developments and usages. So traditionally, we know that gait measurements are done by therapists, and that can be subjective. The therapist can also be burnt out by doing so many assessments. So if we combine technology, we put in technology, we have gait analysis, we throw in artificial intelligence, we will be able to help our elderly a lot in terms of rehabilitation, in the assessment of gait conditions, and as well as in monitoring them. This is a Duke National University of Singapore study, which has been published. It is called the TARGET study. So it includes novel technologies such as sensors and AI algorithms. And they are actually saying that they are the first fall screening AI algorithm in Singapore. So they measure many gait variables such as the step length, step time, stride length, and swing time. And downstream from that, there are the individualized falls prevention protocols that are in place. So they use technology to assess and then subsequently conduct further RCTs such as the SafeTech randomized control trial. This is another review of 71 studies which looks at robot-assisted intervention for falls prevention. So there are 6 types of robot-assisted intervention. For example, cane robots, wearables, exoskeleton robots, rollators. And these robots actually provide 5 types of functions, which I've mentioned here, to detect the fall, estimate the user's state, their motion, their direction, and detect loss of balance. This is another device developed in Singapore by the Nanyang Technological University. It is called the Mobile Robotic Balance Assistant. And it is a hybrid of a robot and a motorized wheelchair. So when the individual is actually walking and doing their activities of daily living, the robot follows the person around and will catch their pelvic area in case they lost balance and are about to fall. The robot can also then transform into a wheelchair whereby the user can operate it. So we can see that this is just one of the novel innovations that we are trying to develop, and eventually, hopefully, all this can be mainstreamed. Now, going back to frailty assessment, just to share with you, in National University Hospital, or NUS, we have developed a rapid geriatric assessment using a mobile app. And this comprises 4 screening tools for frailty, for sarcopenia, for anorexia of aging, as well as for cognition. So this RGA mobile app can be used by primary care providers to do a very rapid geriatric assessment for frail patients. Another review on digital health interventions among people living with frailty. This review includes more than 100 studies. As you can see, there are many, many applications of digital health. Okay, I shall move on quickly to sarcopenia. So I would like to talk about the BIA machine. So in our hospital, we have now linked up with BMEC. This is a private consortium that does rehabilitation, and we have set up a functional assessment center in Changi Hospital to do physical performance measurements for various departments, for geriatrics, orthopedics, sports medicine. And they use the bioimpedance analysis machine quite a lot. So as we know, this is a way to diagnose a low muscle mass as part of the sarcopenia guidelines. So you can see here, this is a printout of the BIA result, whereby it tells you your body fat, the amount of water you have in your body, and of course your appendicular skeletal mass, which you add up the 4 limbs lean muscle mass. So this is very helpful. When you print out the copy, you give it to the elderly patient. You can use it to monitor their condition a few months later when they come back, after you have gone through your interventions. So whole body vibration exercise therapy is also another way that we can use for sarcopenia. I'll go through this very quickly. So this will be applicable to frail patients who can't really do much walking or high-level exercises. And there are already systematic reviews that show that whole body or local vibration therapy can help. This is another Singapore invention, the biceps machine, private-public collaboration. And in these 2 studies that I've shown here, there were improvements in mobility of these patients who use this machine. It is actually the use of electromagnetic fields to stimulate the muscles in the lower limbs. So this, again, is very useful for frail elderly patients who are not willing to really do much exercise. You just put them onto this machine, and there is already evidence that it is helpful. Now, so finally, I'd just like to share a very small innovation, a ground-up innovation. So what I covered previously was the bigger innovations, the bigger tech. But innovation is actually in every one of us. They can be from ground level up. So this is just a small project done by medical students and nurses in our dementia ward to improve nutrition, to improve fluid intake in the demented, delirious patients in the ward. And it was published in the British Medical Journal Quality. And you can see that even small innovations like that can bring a lot of benefits. Yep, so just to end off, I would just like to emphasize that we should view aging positively. We should embrace it all together. We should leverage on technology and innovations to develop new models of care and to develop small projects for innovation and then subsequently scale it and sustain it. Yeah, so again, thanks very much to the organizers of the Thai Forum and also special acknowledgements to my entire Sing Health and Changi Hospital geriatric team.
Thank you very much, Dr. Go, for such a light insights and inspiring presentation. Your expertise and innovation ideas have given us a lot to think about regarding the challenges and opportunities. Now let's continue with our program with our last but not least, Dr. Taiji Ono. Dr. Ono brings extensive experience from the Japan Ministry of Health, Labor and Welfare. He specialized in social security history and comparative health policy with a focus on international cooperation for university coverage. Dr. Ono has consulted for organizations like JICA and ADB and actively engages in research and teaching particularly with students from ASEAN countries. Please, Dr. Ono, share your insight.
Okay, thank you very much for welcoming to this great seminar, and it's a pity that I couldn't join you physically in Bangkok. Next time I'd like to visit, but anyway, I'd like to start my presentation. Let me show your screen. Let me show my screen. Can you see it in full screen now? All right?
Yes, Dr. Ono.
Okay, good. So my theme, given the given time frame, I'm briefly showing the adaptation and the proliferation of new technology to geriatric care in practice in Japan at this moment. So I'd like to extend my coverage to the various matters that the previous speakers, distinguished speakers, has mentioned. But I'd like to focus on the geriatric care aspect and the practice at this moment now. So let me start first. First of all, I'd like to about the context. As you know, the Japan is the fastest and the most aged country, I think, in the world, and the population aging and the decrease of the total population are the underlying factor for various socioeconomic changes and challenges, including the geriatric medicine and the care. The above side, you see their population structure and the trend in Thailand, and the bottom side, you see that of Japan. And the left-hand side, you see the population pyramid. It seems that for the Thai people, that Thailand is already the aging society. But let me bring it down to the end to cover the same scale in the Japan's one. Compared to Japan, Thailand is still quite a young country. You can see it on the left bottom side. For the demand side of the geriatric medicine and care, the increasing of the absolute number of the elderly, and especially those 85 and over, who are more prone to be in need of long-term care and are more likely to become demented, is one of the main factors for raising the expectations of people toward technological advancement in Japan. Left bottom side is the long-term care insurance schemes. We do have public insurance schemes. This is a certification rate by age. As the age climbs up, the certification rate will go up. On the right-hand side, it is the number and the percentage of the demented elderly of all as of total elderly population. In 2022, it is about 12.3%, namely the 1 in every 8 people age 65 and over are demented. For supply side of the geriatric medicine and care, decreasing the absolute number of working age population is one of the leading factors that necessitates a technological innovation. On the left-hand side, you see the projection of labor force in health and welfare field. On the right-hand side, you see the change of the absolute size of the labor force. What I want to say by this graph is this one. Total labor force in health and welfare field will be about 1 in every 5 worker of all labor force in 2040, compared to just 1/8 of all in 2018. So it is a tremendous number. 20% of the total population will be working in health and welfare sector. Whether it is possible to do so or is a main challenge. So both we need to think about the supply increase and the demand reduction for the working for the labor forces in working in the health and care field. And the technology could be one of the methods to cope with that. Digging a little bit deeper into the geographical differences of the population structure in Japan. These are the graphs showing the number of the people in the in various types of societies in Japan. You can see the 5 lines starting from 2020 to the estimate of 2050. So from upper 2 lines are the size of the elderly population. And the bottom red line is the total number of population. And these orange and blue lines are for the younger generation. So you can see that compared to the metropolitan area, where elderly increases, but the younger generation's absolute number will remain. But for rural areas or less populated areas, even the elderly people will decrease like this. In 2050, in urban areas, aging will continue, but absolute size of younger generation is stable. In rural area, even age 65 will decrease. Younger generation will be around half of 2020. This is a massive changes of the population structure that necessitate the kind of innovation, as you say, of course, the technological innovation as well as the policy innovation to cope with that. So today I'm talking about the technological aspect only, but the policy innovation is also essential. Next, I will talk about the care technology, the technological aspect. And these are the samples that are utilized. I will show you the data later, but these are the samples of the utilized care technology at this moment in Japan. You can see these four pictures are showing the use of the smartphone headsets as monitoring sensors to enhance productivity at the elderly care facility settings. Right-hand side, you see the use of lifting assistant machines, and left-hand side is the pet robot chatting. Actually, government is providing subsidies to service providers, or most are private ones, for the introduction of these care technology. Also, government has assembled a manual for service providers upon the introduction of such technology. And these are the prioritized areas for the development and diffusion of care technology jointly set up by the Ministry of Health and Labor Welfare and Ministry of Economy and Industry. There are 7 areas of the technological, technological target areas. First one is a lifting one. Second one, walking assist. Third one, toilet assist. Fourth one, bathing assist. Fifth one, observation and communication. Sixth one is administration support. And seventh one is the others. These are the targeted areas for the development of care technology. And the third one, I talk about the policy framework for proliferation of these technologies. In Japan, as you may know, both medical care and a separate scheme of long-term care is provided universally, covering 100% of population as public social insurance schemes. And the finance is public, actually. But the service provision, like this one, hospitals or service care facilities, they are mostly the private entities. They are non-profit, but private ones. And basically, for private ones, government cannot order to do so something rather than to economically incentivize them to do so. And the most influential method is what we call as the fee schedule, which refers to the price list of the covered services under public schemes. It is applied to the payment of the services provided from public insurance, both the medical care and long-term care. And including the use of technology, it is applied. In the fee schedule for long-term care insurance, these items are covered. And the elderly who are assessed as in need of such technology can borrow or purchase such devices at discounted out-of-pocket expense, and the remaining part is paid by the public insurance. And these are the examples, not all, but examples of the covered items like the AirPods, water bed pads, like air bed pads, move body position, monitoring sensor for demented elderly to prevent wandering around, automatic toilet treating machine like this. For the purchase, monitoring sensor for urination, you can put some pad in your abdomen to recognize if you need to go to the toilet. And the replacement unit for this kind of machine is also purchased at discount prices. And second way of proliferation of such technology is a preferred treatment or in fee schedule. Currently, it is applied for the use of the sensoring devices at nursing homes. Bed pads with sensors to monitor the state of sleeping of the elderly, like this picture. Sensors are laid on the on the bed, and the care workers at the office can notice in each room's elderly whether he or she is asleep or waking up or in need of help. These kind of sensors will enhance the productivity of the care workers and reduce their burden of work. To encourage the use of such technology, under this fee schedule applied for all the facilities, special addition payment is applied on top of the basic fee paid per person per day basis for the use of such devices. So that if you use such machine or such device, you can get more from the long-term care insurance fund. And also the relaxed regulation for the minimum number of care workers per resident is applied if you use such devices, because it is to enhance the productivity of workers. And to be included in that fee schedule, something like the health technology assessment is applied for the use of these kind of new devices. There are several viewpoints to see, but the most important part is this one. Enhancement of the effectiveness, as well as there is no safety concern upon use. So these type of evidences are provided from the manufacturer to the government, and some governmental committee will discuss whether it is appropriate or not to include. Upon the introduction, also, of course, the effectiveness and the safety is observed, and after that, various viewpoints, such as its economic efficiency or effectiveness or impact to finance, is also considered to be included in the list of the services that is covered by the public scheme. And now it is care technologies state of proliferation. These are all service providers and long-term care facilities. What type of care technology is applied? It tends to be more in the facility settings. This kind of care technology is applied. Software used by personal computers here, and tablets or smartphones, these are maybe the exception because the tablets may be necessary for the home visit situation rather than institutional situation, like the to have the text communication between the remote distance people. Monitoring sensor in rooms. Actually, 67.4% of the long-term care facilities in Japan are using that kind of bed sensoring devices. Camera type sensor or other type of sensors are used in long-term care facilities. And other ICT devices are used, wireless nurse call buttons, headset neck speakers to communicate in different rooms. Of course, the Wi-Fi settings are proliferated. And this bed sensors proliferation rate may be the effect of the policy that encourages the introduction of such technology under the fee schedule scheme that I mentioned. Care robots are not proliferated compared to the ICT devices or the sensoring machines. Lifting support, assisting the move of the elderly, this percentage. Bathing assist, 7.6%. Toilet support is only 1.0%. It is less used at this moment. But introduction of the care technology has a good effect for the workers in the care settings. Reduce work burden in daytime. More than half of the facilities says yes, that their care workers' work is reduced. Nighttime, about 50% also. About 30% shorter working hours, less overtime is observed. And 1/3 says that the vitalization of workplaces is shown as well. It is quite important to attract more workers to the care industry. And improved quality of care is observed in long-term care facilities. And several measures, such as the abolition of simplified unnecessary duty of a procedure, or changing the mindset of personnel in charge of business that utilize care technology, is now provided by the care service managers. So that the care workplaces have changed by the introduction of technology, which encourage the people to use that. So that's all what I have prepared for today. And thank you for paying attention. And I'd like to respond to the questions and things that I should have covered, including the issues like the Alzheimer's drug use that my previous speaker said, or the policy innovation, or regarding the issue of the frailty prevention, or scientific, like the use of the ICT technology or use of the data set to improve the care service itself. Thank you very much for paying attention. Thank you.
Thank you, Dr. Ono, for such a terrific presentation. I believe the details you share were exactly what the audience need to hear. Your perspective on technology and innovation has truly been thought-provoking. Now, I would like to open the floor for questions from our audience. If you have any question or comments, please feel free to raise your hand. ค่ะก็สำหรับท่านใดที่มีคำถามนะคะสามารถถามเป็นภาษาไทยได้นะคะทางเราจะมีล่ามนะคะช่วยแปลเป็นภาษาไทยให้ค่ะค่ะ
Thank you for the wonderful panel, for the wonderful presentations. I have two questions. One goes to Professor Go. The first question is, according to the Kampong Admiralty or the community care apartment, is there the liaison between geriatrician and this kind of community? If not, how do you see the role of geriatrician to support this kind of aging? And my second question is that since there are so many types of technologies mentioned in this session, what kind of technology do you see that is the most fit to support or encourage aging in place, especially in terms of practicality and cost effectiveness? Thank you.
Yeah, so thank you for the question. So I think your first question was about the kampong, which is the village concept of elderly living. So this concept actually integrates these elderly living in small rooms, small studio rooms with enhanced infrastructure to take care of them. There's monitoring. They are all linked to an active aging center, which is just down their block. And as well as the health center that I was talking about, it's actually a primary care facility. So there's actually no specialist input that is readily accessible. But because of the active aging center that is there, as well as the primary care facility that is there, I think they can get timely medical care if they need it. So they will all also be supported by community case managers and community nurses. There are also many tiers to this support in the community, so that any red flags that come up will be readily addressed. In fact, if I think these elderly patients would probably all be enrolled with their, number one, their primary care provider, and if they are frail, I think most of them would also have a geriatric specialist clinic consultation and follow-up. Yeah. So as for your second question, it's about what aspects or the types of technology that you feel can be mainstreamed. Is that question for me or for Prof? Okay. Yeah. Okay. Maybe I'll just say a few words first. But I think in the Singapore setting, what really accelerated over the past few years is telemedicine, as well as telemonitoring. As for all the other, rehabilitative, falls prevention devices that you see, a lot of them have not been mainstreamed yet. So they are all consist of very small, grant-funded projects. So a lot of them are funded by the National Medical Research Grants or by philanthropic grants, and they are all, scattered all across the healthcare landscape, from the acute hospital to the community institutions to the day center. So a lot of that are still very small pilots that have not yet to be mainstream. So the challenge of how to then mainstream it and make it accessible to everyone, I think it will still need many years of development, because we know our government is also very conscious about cost, about having too much cost to it. So yes, they give you a lot of seed funding to try out all these new gadgets and to do all these research projects, but to scale it, I think you need to do a very detailed cost effectiveness analysis, and it has to be, number one, clinically proven to be efficacious. Yeah, so that would still need some time.
Okay, for me, I think the first question about the role of geriatricians to promote aging in place that you mentioned, I think in some aspects it's quite difficult for general practitioner to take care of other people at home, especially for those with complex medical illness or frail, or in those with multiple comorbidities and use of a lot of medications. In that case, might still need geriatricians to harmonize the care for people to living at home. And the second question is about the innovations or technology that might be most effectiveness to promote aging in place. I think the innovation and technology might not be the digital or the digitalization, computerization, or the machine only. Just as you just saw from recent from all of us, we try to talk about the care system as well, because many of it is if we develop the service, the new service or the care system, it is also called the innovation. And for example, in Thailand, we try to have the home intermediate care to see the patients with intermediate care at home. So I think this might promote aging in place as well. And many of the aspects that both Professor Ono and Dr. Sun just mentioned, also the care system, the new service design. So this is maybe I think it's effectiveness and can be used in everywhere. I think because it's not just
Still have the time, can I ask? Okay, I have the question to Professor Ko. I'm a lecturer from Chiang Mai Ratchapat University. I'm teaching about the elderly care, and now I'm doing about the fertility program. And as you share the information that you have the screening the fertility in Singapore, both in the hospital and in community, I would like to know what is the percentage of the mild and moderate and severe of the fertility in community. And as you do many intervention, I would like to know, like the after you evaluate, are there any percentage changing from the fertility severe convert the moderate or moderate back to the mild? That is will be convincing us to do more for the effective intervention for field. Thank you so much.
Thank you. So I think if you look at the elderly population as a whole in the community of Singapore, it is about less than 10% actually are frail for elderly. But of course, as you go higher and higher in the age group, then that percentage will increase. What we are seeing is actually frailty in the acute hospital that is really, really very challenging and consume a lot of resources. So in the acute hospital, I would say at least 50% of them coming to our acute unit, in fact to internal medicine, and in fact every other specialty, I would say about half of them are frail. So that's the challenge, because you know they are going to stay very long in hospitals, they're going to get a lot of complications, and they never get well. They just keep accumulating more problems in the hospital. As for your question about actually making a person go from mild to non-frail or severe to moderate frailty, I would have to say that our Singapore healthcare system is still not that good enough yet to be able to have evidence to reverse frailty. It is a dream for us to be able to do that. At this stage, I think it is important to first recognize it, and not just for the geriatrician to recognize, but for everyone in the healthcare system to recognize it, whether you are a primary care provider, whether you're a community nurse, and also whether you're a specialist that is not a geriatrician. And so we also have an education program to educate the non-geriatric specialists in our hospital. That includes the surgeons, the cardiologists. Everyone else in the hospital has to be able to embrace the concept of frailty, recognize that they are not just treating this specialist condition of the patient, but to look at the patient as a whole and to treat the frailty. And it is not easy for that. Until then I think we can be able to have a better outcomes in terms of interventions for frailty.
Can I just share about the information in our previous study about frailty in community in Bangkok and in 5 representative provinces of the countries. The percentage of frail is allowed 10 to 20% depending on the study. But the pre-frail status is might be a bit more, allow more than maybe 20 to 40%, and the rest are fit. But the intervention, this is one of the things that the intervention, usually we provide exercise, comprehensive geriatric assessment, nutritional support and something. But one of the things that we learned from that study is the benefit of the reversal of the pre-frail to fit. This is still possible in some cases. Usually the success is from monitoring, that we have to monitor, and if it's not by the digitalization, not by the anything, but the source of information, a lot of older people, even in Bangkok, they still prefer to use maybe the form of the hard copy, poster, brochure, or not in forms of the digitalizations of the resource of material resource. This is why we think that sometimes innovation is not it not has to be the computerization or the machine. It can be the process of the intervention as well.
Dr. Ono, do you want to share too for this question?
No, at this moment I don't.
Okay.
Okay.
Well, this
Yes,
is...
I think the time is limited, so please. Yes.
Okay. This is a very interesting question. And okay, another one is the last question.
And sorry to excuse. And thank you for your congratulations for all speakers. I'm from Dr. Nguyen from Myanmar. So I would like to ask Professor Undu. So there are 2 systems in innovation. Number 1 is system innovation, and you mentioned focus on technical innovation, Professor Undu. So you just mentioned about the robot and sensor. So I'm just wondering whether we are applying for general principle or generative medicine, that it covers the social, environmental, functional, memory, and mood. So you are technical innovations such as sensors and robots can cover every aspect of the generative medicine principles. I would like to know that. Thank you very much.
Excuse me,
Well,
you ask all speaker or for... Oh, no, okay.
Okay, all right. I think I think it is there is no magic bullet in technology that can solve every issue. I think what should be addressed commonly is to the engagement and social participation by the elderly, which is very difficult to be replaced by the technological innovation. We have seen some, communication devices progress, especially during the time of COVID, to have this kind of online video chats or like the, to chatting with the elderly living in the nursing home can chat with their granddaughters at home like that, but it cannot replace the kind of emotional or intimacy or the affection kind of relationship between the people. Therefore, I think the technology itself is quite effective in some aspects, but there is many places that cannot be replaced by the technological advancement. For I think what maybe we need to think about is this kind of a community-wide development type of policy innovation to realize the kind of age-friendly society or age-free society society, because in our country, in Japan, already more than 50% of the elderly, 50% of the people living in that community are over 65 years and older. So that kind of community, creating the age-friendly society is a creation of the community, or creation of the community itself, community development itself. It's the same word, same concept. So that kind of policy innovation is what I think we need to think about in parallel with the technological advancement. And I don't know. I could answer to your question exactly, but this is what came to my mind at this moment. Thank you.
Thank you for the questions. And it's time. We hope you have enjoyed this session and gained a lot of valuable ideas and knowledge. Before I hand the stage back to Kun Pechada, let's give our speakers another big round of applause again.
Thank you.
So, thank you very much, Dr. Manita, and also to our speakers. I want you to maintain on the stage for a moment to take a photo. So thank you again. And we will have 5-minute break, so you can go outside to the toilet to refresh yourself and come back again here. ไปเขาบอกให้เบรก5 นาทีเขาจะตัด ถ่ายรูป Welcome back. We are about to the last session. The session is Dementia Management of the Elderly Technology and Innovation. This session will address what and how innovation and technology is being utilized to improve care for individual living with dementia. So, please join me in welcoming our moderator, Dr. Jesada Kheokaji, from the Neurological Institute of Thailand and his speakers. Please give them a big applause.
Okay, good afternoon, ladies and gentlemen. Now I welcome you to the session of technology and innovation. We specify for dementia in elderly. I'm Jesada Kheokaji from Neurological Institute of Thailand. Will be moderator in this section. We are grateful to have an opportunity to talk with three Thai experts who have committed themselves in the field of dementia for both investigation and the treatment part. I would like to introduce our speaker first. The first speaker start from Associate Professor Dr. Warapan Senanarong from Faculty of Medicine, Siriraj Hospital. Dr. Warapan graduated from Faculty of Medicine, Siriraj Hospital, and then she studied in the tropical medicine at University of London, UK, and she pursued a study in the geriatric medicine at Royal Victoria Infirmary, Freeman Hospital, and Newcastle General Hospital. And then she also received the Collaboration Award from 2004 to 2006. She has been a faculty member at the Faculty of Medicine, Siriraj Hospital since 1995. And she also found the first memory clinic in Thailand, and she is among a pioneer in the dementia translational research in Thailand. She interested in many things about dementia, now especially in the digital neuropsychological test and also the fluid biomarker assessment within the memory clinic setting. And the second speaker, Associate Professor Chanisa Choti Panit from Julapon Hospital. She graduated from Faculty of Medicine, Thammasat University, and then she pursued in the residency of nuclear medicine from Faculty of Medicine, King Chulalongkorn Memorial Hospital. And then she attended the IAEA Fellowship Study in Nuclear Medicine at the Division of Nuclear Medicine Hospital of University of Pennsylvania Medical Center in the United States of America. She is now among the experts of the PET scan and the cyclotron measurement in dementia, especially for the amyloid and tau PET scan for dementia assessment. Now she is the expert of nuclear medicine in Julapon Hospital, associated with the National PET and Cyclotron Center. And the last speaker is Assistant Professor Paranyu Julayanon from Department of Neurology, Bamrungrad International Hospital, Bangkok, Thailand. He graduated from Faculty of Medicine, Chulalongkorn University, Bangkok in 2011, and then he go to study in a clinical fellowship in behavioral neurology in the University of Florida, Gainesville, Florida. And then he also graduated from study many things, including the neurology and the behavioral neurology session. And he also had many experience in the career in the United States as the assistant professor of neurology in the Division of Alzheimer's and Memory Disorders at Barrow Neurological Hospital, Arizona. And then after his long experience in the United States of America, he come back to Thailand and pursue the study in the dementia as behavioral neurology in Bamrungrad International Hospital. Let's introduce to the session with the first speaker, Dr. Warapan.
Thank you very much, Dr. Jesada. Dear doctors, my talk would be about the same topic here, technology in innovation, especially what we experience in our hospital. We know that the next generation of care, of dementia care in nowadays tend to start from prevention, from change of the lifestyle, using, hopefully we can have a good, healthy, happy period of life during elderly age. We can introduce by symptom detection using screening tests of various things, using cognitive tests, checklist on the symptoms, checklist on blood biomarkers or CSF biomarkers if you're there to do that. And clinical assessment can be changed into digital assessment so that we can have continuous data and can be approached from anywhere, from Internet of Things that we can do. As I said that this change in digital technology has a strength that it's convenience. You can approach from your computer or your laptop or your mobile telephone. It generally can generate continuous data. With these digital, we can use AI to take these data to help in terms of assess, interpret. And it can be used early to detection and can use to monitor whatever intervention you give, pharmaco or non-pharmacological. This can start from simple test, demographic data, blood test, genetic data, EEG, or blood biomarkers. But with these change into digital technology with other monitoring, just sensor objects so that you can use to measure the sleep, to measure the hearing, the vision, or mobility. and this can help in terms of early detection. Nowadays, we can help using biomarkers to give diagnosis of Alzheimer's disease by saying that, do you have amyloid, do you have tau, and do you have other neuropathology originally from amyloid, tau, and neurodegeneration, that means brain shrinkage. And it depends on A plus or minus, T plus or minus, N plus or minus. If you have A minus, that means you don't have Alzheimer's disease. Even you have other pathology like no tau, but necrosis, then you can need to look at other non-amyloid, non-tau pathology. Recently, they also add the biomarkers classify into, you can use CSF, plasma, or neuroimaging that Dr. Shanisa will talk later for diagnosis, for disease monitoring, and for other neuropathology such as p-tau 217 can use for monitoring and for diagnosis. And all these for staging, you can use NFL or TBBR tau 247 or p-tau, other p-tau forms. This inflammation also help in terms of detect disease progression like GFAP, and also this NFL can reflect other neuropathology as well. We know that if these change in terms of amyloid change, tau change from PET scan from the start from medial temporal lobe and also progress to neocortical uptake, and then you can know that there's a necrosis or shrinkage in terms of atrophy, in terms of MRI, and then cognitive tests show abnormality. If these biomarkers change earlier, left shift, that means they're relatively temporal change in terms of there might be other pathology, but if you affect a cognitive reserve, or the curve will shift in terms of to the right, but clinically still good. Like they are in early stage of dementia or MCI stage because of better brain reserve. Talking about blood biomarkers, you can see booths of blood biomarkers outside as well, amazingly. However, blood biomarker is changed different from CSF biomarkers in terms of they have to travel through blood-brain barrier from CSF to blood, and also it may be diurnal variation in terms of day and night, or even during the day, and it depends on method of passing transport from CSF to blood, and the concentration in the blood would be much smaller than in CSF. So you need a machine, need a technique to be able to detect. And not just amyloid and tau, you can have blood biomarkers for other pathologies such as microglia activity, lipid activity, clearance biomarker, and synaptic biomarker, astrocyte biomarkers. As I said, these biomarkers may not be able to detect travel to blood-brain barrier and go to blood. So it depends on which one is more comparable, measurable in blood, like A-beta, p-tau, NFL, and GFAP are more pronounced in blood than other things such as cytokines, TREM2, or GAP43. In our lab, we also have automated similar measurement of blood biomarkers. We have got grant from Health System Research Institute on Thailand Science Research Innovation and also Siriraj Foundation to set our own cutoff point in our lab in Thai people. we have also single cutoff point, and now they recommend two cutoff point using positive or negative value. For the positive value is cutoff point that we have by using both CSF and amyloid PETs is more than 1.12 with accuracy specificity of 86, positive predictive value of 86, negative predictive value of 60. So it's not too bad in terms of in our population. Not just a blood biomarker is a new technology. You can have wearable devices. It can use for screening, for diagnosis, and also sensor can use to detect other things like sleep, falling possibility, and these can pull into big data so they can have big data and AI analysis to improve diagnosis. Other things that wearable device can help in terms of care is posture control and gait abnormality detection. So it's beyond the clinic that we can monitor our patients. It includes in their environment as well. Now the other technology that can be used in Alzheimer care is telemedicine. Now we have a teleconference between one center to other center. You can have now internet of medicated things. IoT can help in terms many things. Dispense the blood to a robot, computer, and IoT can help in terms of smart environment detection, as I say that by using environmental wearable device as well. However, each technology can be applicable. It depends on stage of the dementia, early stage, mid stage, and late stage, like application for screening or detection, diagnosis of Alzheimer's disease, or even robot helping. It can use in early stage of dementia. For these application, it's maybe not suitable for middle and late dementia stage. Robot can help in terms of middle and late dementia, is more helpful. Medicine dispenser can help in terms of from early to late. Communication platform you can use and communicate to computer by playing games or other things through all stage. And lifestyle monitoring is important, especially more confined to your home. Okay. So GPS is more important in terms of detection. In our lab, we also have these gait device and monitoring in the limbs to detect mobility combined with EEG and or sleep monitoring. And all this data can pull into health diagnosis and also staging of the people. We have our data pulled together and use machine learning to help think that which measures is more important in terms of our cohort to detect. We have brain volume, we have cognitive tests, we have neuropsychological tests, and also neuropsychiatric assessment. You can see it in Thai cohort. Brain volume with the standard cognitive assessment is good. Accuracy range from 80 to 90%. And just these certain cognitive assessment like TMSE, clock drawing test, and also verbal fluency test can give accuracy of 88%. We then, with this information, we develop digital cognitive screening assessment that can use at home to promote early detection. What we have is like CamCog, is a famous digital assessment by Cambridge. But it's so detailed. We use in our lab and it's too much complicated and in our population for Thai. So what we use this, you can approach from this app. And we use this digital assessment, and what we found is with this digital assessment to detect dementia, area under the curve is 0.88. To detect MCI is a bit low, but with these we use just verbal fluency, category fluency, and give specificity of 80%. It's kind of acceptable for screening. Okay, so it's not too bad. Try this when you're at home. So I conclude that this new horizon of dementia diagnosis and care management will use in terms of digital assessment, Internet of Things, wearable device, and all those new technology, including blood biomarkers. Thank you.
Thank you, Dr. Warapan. Now, for another view of dementia technology from nuclear medicine radiologists, I believe that today is an era of advanced brain imaging modality, especially the PET scan, and Dr. Chanisa is one of an expert who pay attention to the amyloid and tau PET technology. Please introduce us about what you are doing study now.
Okay. สวัสดีนะคะ Good afternoon and thank you for joining today. First, I would like to ask some question. How many of you heard about the PET scan or molecular imaging before? Please raise up your hand. Just only 1, 2, 3, 4. It's not much. Okay. Okay, for sure. For sure, the PET in this sense is not animal that you feed at home, but it's a technology. Okay. So we will start with the general idea about the PET scan in dementia. Okay. Further, regarding the degrees of diagnostic certainty in dementia syndromes, the pathological diagnosis is a definite diagnosis, but you have to wait for the patient to die. If we can detect, we can diagnose before that, it will be good, right? It will be good. So if we can look at in the brain before that, it's very good. So this is a role of the molecular imaging. It's the role of PET scan. It's an antemortem diagnosis biomarkers indicating for pathologies. It's the role of PET scan. As a molecular imaging, PET is the stand for the positron emission tomography. It's a diagnostic imaging test, measuring the concentration of the molecules in the brain. Because if we look at the brain, look in the protein in the brain. So this is a picture of the PET scan. A PET CT or PET MRI is a two-in-one testing. It's a hybrid imaging, two machines in one machine. Okay, this is a PET scanner combined with the MRI scanner or CT scanner. When you look at the PET provides the cellular level information such as the oxygen use, hypometabolism, glucose metabolism, or the blood flow in the brain that reveal the problem, the medical problem that a very early stage in the brain. But the CT and MRI provide the anatomical information. That means the patient will get both the cellular level information and anatomical information in one testing. This is a PET images. This is a CT and this is a MRI. This is the fusion images of the PET CT and PET MRI that we call the anatometabolic or anatofunctional images from the PET CT or from the PET MRI. How it work? How it work? PET, how it work? We synthesize the radioactive compound from the cyclotron. The cyclotron is a machine. The cyclotron is a machine here. It's making the ion or particles into the high energies to produce the radioactive compound with the good quality control and then inject to the patients. When they inject the radioactive to the patients, the scanner will detect the signal that emit from the body. And what we can see, the capture image like this. The capture images like this, allowing to see the function and detect abnormality in the brain or in the body. This is a PET scan. Here is the detail of the radioactive compound. Radioactive compound we call the PET tracer for the brain imaging, including the glucose metabolism, we call the FDG, neuropathological process, neurotransmitter system, and the last one is oxygen utilization. Concerning the prevalence of the pathology's contribution to dementia, when you look at the graph, Alzheimer's disease is the most common type of the dementia, right? So Alzheimer's disease is the most common type, right? So the PET tracer, it will focus on the glucose metabolism, is the FDG, and neuropathological process, including the amyloid plaques and tau radioligands. Why are these tracers is important for the AD diagnosis? Why is important? I think that you may know the pathological hallmark of the Alzheimer's disease is extracellular amyloid beta plaque and intracellular neurofibrillary tangle of the protein tau, which lead to the cellular degeneration, reactive gliosis, and synaptic dysfunction, and finally is a neuronal loss. So the PET scan will detect the deposition of the abnormal tau and protein and synaptic dysfunction in the brain via the DIS tracer. This is the action of the brain, PET scan. This is a research framework by the NIAAA. There are 3 AD biomarkers. It's the ATN. A is aggregated of amyloid beta. There is amyloid beta PET. And T is aggregated tau, is tau PET. And the last one is N, neurodegeneration or neuronal injury, is FDG PET. When you look at the table, you can see that in Alzheimer's continuum, Alzheimer's disease is defined by the abnormal both of amyloid and tau. Both are required. That means it's A positive and tau positive. It's defined by Alzheimer's disease. This is what we call it, with respect to the AD. This is a model of the disease progression of the AD. It shows the sequential of the development of the disease from the pathological amyloid to the tau pathology to the structural changes and finally cognitive symptoms in the AD continuum. It believed that the first pathological event in AD is amyloid beta accumulation. That if we can detect the amyloid in the brain in the preclinical, we hope that this is early diagnosis of the patient with the AD. And the tau PET show the association with the disease progression. But the FDG PET is not the direct biomarker. You can see the hypometabolism, that means the decreased uptake in the brain. It's a result from the non-specific process of the brain. It's not that AD specific can occur in the broad range of other diseases. As I mentioned, FDG is not specific for the AD diagnosis, but the typical pattern of the FDG can help the radiologist to diagnosis of the other neurodegenerative disease as PD, Parkinson's disease, MSA, PSP, or CBD. This is useful of the FDG PET. Here is the images of the MRI images and the PET scan using the FDG, amyloid, and tau. The upper row is a healthy brain, and the lower row is an Alzheimer's brain. If you look at the lower row, here is the MRI images. It shows the generalized atrophy of the brain, and for the FDG, show the decreased uptake here at the bilateral frontal and bilateral parietal and temporal regions, including the precuneus and posterior cingulate. When you look at the amyloid plaque, this patient has amyloid plaque in the brain, at the whole brain, with the tau pathology at the left temporal region. This is typical of the Alzheimer's brain. Okay, next, let's look at the 2 cases. Number 1, a 69-year-old female diagnosis of MCI, amnesic subtype, age onset is 68 years, episodic memory loss, dissociative syndrome. The MRI is negative. Then the patient was sent to do the PET scan with the amyloid. The amyloid showed the positive with the amyloid plaque in the brain. It's the whole brain. After amyloid PET for 1 year, the disease is a progression. With the episodic memory loss, irritability, depression, and MoCA is 17. Diagnosis of Alzheimer's disease. This case is the example of the benefit of the PET scan in MCI. Because a patient is start with the MCI, right? So this is a benefit of PET scan. What is the benefit? The benefit of PET scan is a AD prediction. AD prediction. What is the AD prediction? When you look at the mild cognitive impairment in the patient, not everyone with the MCI may have the AD, and MCI patients may or may not progress to dementia, but the risk of conversion in dementia is increased in MCI. So if the patient has MCIs, can be considered as a risk factor to developing to the AD. That means if you do the PET scan with the amyloid and positive, is for 1 year conversion rate to the AD is about 50%. But if the PET scan is negative, it's just only less than 10% conversion to AD in 3 years. You feel good, right? If the PET scan is negative, 3 years, not the Alzheimer's disease. Okay, case number two. A 60-year-old woman with the memory complaint. The MRI just showed the generalized atrophy of the brain. Sent to the PET scan to do the PET scan with the ATN. This is images is typical for the Alzheimer's disease. You look at the tau PET MRI. Yeah, these images, this is abnormal tau protein at the frontal region and the parietal and temporal region and the posterior cingulate and precuneus. And for the amyloid, how about the amyloid? Oh, this is amyloid plaque in the whole brain. This is an abnormal amyloid plaque deposit in the brain. For the FDG, it shows the decreased uptake in the frontal and bilateral, temporal, and parietal regions. For the accuracy of the PET reading, these images we call the 3D SSD with the Z-score overlay compared to the normal database. Based on the age map of the data, the blue denotes the minus 2 standard deviation, but the purple is a -3 standard deviation from the normal. Okay, from these two cases, I think you can better see that PET is a benefit, right? It's a benefit. What is the recommendation for the clinical use? This is the appropriate use criteria for the amyloid PET by the Society of Nuclear Medicine and Molecular Imaging and Alzheimer's Association. This is an indication for the amyloid PET. Patients with the persistent, progressive, and objectively confirmed or unexplained cognitively impairment, AD as a possible, but the diagnosis is uncertain. With the atypically early age of onset, unclear clinical presentation, atypical clinical cause, and etiologically mixed presentation, and if the clinician think this PET scan is increased diagnostic certainty and outcome management, you can send the patient to do the PET scan. And nowadays, PET scan is recommended for the selection of the AD patient to obtain the anti-amyloid antibody treatment and monitor the amyloid plaque and the brain clearance from the brain. This is a role of indication. This is the first report in the trials with the anti-amyloid antibodies. Before the treatment, you have to do the PET scan. You have to do the PET scan to confirm that you have the amyloid in the brain or not. Okay, if you have the positive, and then you treat. Okay, maybe 3 or 6 months later, you have to do the PET scan again. You can see that the clearance of the amyloid plaque from the brain, from the PET scan, yes, you can see, it's a decreased uptake. And from the MRI, you can see the edema and the microhemorrhage from the brain because of the effect of the treatment. Okay, before the ending, I would like to leave the home message. PET images is an early diagnosis and monitoring of the patients during the AD progression. FDG is an improved diagnostic. FDG, amyloid or tau, or the PET tracer is an improved diagnostic in the dementia early diagnosis and can determine the MCI due to AD and differential diagnosis of the AD to the non-AD dementia. Amyloid PET is the earliest hallmark as AD. It's a belief, just a belief that amyloid plaque is the earliest hallmark. And predict conversion from the MCI to AD. And tau PET. Tau is related to the cognitive impairment and the strong relationship with the neurodegeneration. And FDG, that I told you, FDG is just not the AD diagnosis, but can help to differential diagnosis of the other neurodegenerative disease. Maybe you have the question, oh, the PET is look good. But how accurate is a PET scan for detecting Alzheimer's? And what benefit does it have on treatment decision? We found that PET is reliable and powerful function with the sensitivity is about the 95% and specificity about the 100%. And PET scan results can change the clinicians treat patients, include use of the medication and counseling. In 2021, we had the research publication in Thai people on the title of the impact of molecular imaging on the diagnosis of dementia subtypes. We found that changed the final diagnosis in 60% of the cases and was able to resolve the 95.2% of the diagnostic dilemmas. And it's a accurate diagnosis can help direct therapy, improve care plan, and avoid unnecessary drug prescription. This is a benefit of PET scan. And I think that's before the end, I think maybe you have the question again. How much does the PET cost? How much the cost? I can tell you it's very expensive. It's very expensive. For the US dollar, is the lowest is about 900 US dollar. But in Thai, it's about 25 or 28,000 baht for just one tracer. If you do 3 tracer, you can multiply by 3. Okay? Okay, thank you very much. That's all. This is a general idea of the PET in dementia. Thank you.
Thank you, Dr. Chanisa. And now we have another neurologist who has expertise in behavioral neurology and cognitive disorders. Dr. Pranyu had a lot of experience taking care of patients in United States, and for the special, he also had an opportunity to participate in many clinical trials, including the direct experience with anti-amyloid treatment in United States. Can you please provide us about your past experience and your past work?
Thank you so very much for the organizing team to invite me to share the experience with everyone here. And thank you every audiences that you guys stay awake at 3 p.m. So if any of you want to take some break, get some coffee, or stretch out your arm, feel free, okay? So many people think about dementia as very devastating disease. Alzheimer's is uncurable, not treatable, right? So now is a game changer. So we have many newer treatment that is not the final solution, but it could be the door opener for the future treatment in the next 10 years, 20 years down the road. So let me share with you about the dementia treatment. This is very kind of like a simple graph about what are the medication that we have right now for the treatment of Alzheimer's disease. Specifically, we're going to talk about Alzheimer's, not any other type of dementia today. So we have cholinesterase inhibitor for a long time, 20, 30 years already, nothing surprise, right? We have memantine that is used for the moderate or severe dementia, and treatment of behavioral symptoms, depression, anxiety, aggression, agitation, those are very important to take care of people with dementia, in particular to improve the quality of care and quality of life. And the last one that everyone is looking for is the anti-amyloid therapy, and I'm gonna touch a bit on that at the end. Cholinesterase inhibitor. everyone know that there are 3 cholinesterase inhibitor in the market right now in Thailand as well. Donepezil, galantamine, rivastigmine. And the side effect could be stomach upset, diarrhea, slow heart rate, or nightmare, or nausea and vomiting. Those are the side effects of the medication. So it's not only beneficial for the memory or cognition, but it's also helping with some behavioral aspect, and also it's help with the delayed nursing home placement for the patient as well. Next one is the memantine that I mentioned earlier, that is for moderate to severe dementia. It can be used as a monotherapy, or it can be used as a combination therapy with cholinesterase inhibitor. These 2 medications doesn't have any strong evidence, and is not FDA approved for the treatment of MCI or mild cognitive impairment. And the last one, and the third one is the neuropsychiatric treatment: depression, anxiety, irritability, sun drowning symptom. I would like to focus that every single of the medication that you see on the slide, this one, none of them are actually US FDA approved. Every of them are off-label use for the treatment of behavioral symptom. The only one new thing that recently approved by the US FDA a year and a half ago, is called brexpiprazole or Rexulti. And this is for it's an antipsychotic, and it's approved for the treatment of agitation in people who have dementia from Alzheimer. We have a lot of medication to help with the sleeping, melatonin, orexin receptor antagonist, trazodone, mirtazapine, agomelatine. Those are kind of like safe medication for sleeping, for the insomnia, and avoid Seroquel, avoid benzodiazepine, Xanax, alprazolam as a first line for the treatment of sleeping problems in people who have dementia. So these are the basic concepts that we have been using for the last many decades in people with dementia, because none of the medication that have been developed for disease-modifying therapy has met the clinical outcome in the last 30 years, 20, 30 years. Until the last couple of years, that there are a couple of the medication that recently approved by FDA as a disease-modifying therapy. Before we talk about disease-modifying therapy, I would like to draw attention to what is the pathomechanism of dementia from Alzheimer. If you look at the right side of the slide, this is a normal pathway. Everyone have APP protein, and there's some cleavage of the APP protein and causing like a oligomer, and those oligomer become soluble and dissolve. So that is a normal pathology. But in people who have Alzheimer's disease, the pathology is different because the cleavage of the APP protein is on the different side, and making those proteins become insoluble. It's not resolved by itself. It's not reabsorbed by the spinal fluid or the blood or the lymphatic system, and it's become depositing inside and outside of the neuron in the brain. And that is why Alzheimer's happens. And those two proteins are amyloid plaque that could induce the tau protein later. And the disease-modifying therapy right now is mainly focusing on the amyloid protein in the brain. When we talk about the treatment of Alzheimer's disease, if people come to you and don't have Alzheimer's and never have any treatment, no medication, this is the progression, the green line at the lower bottom. Everyone gonna progress, right, with a faster rate. And then when there is a disease symptomatic treatment like galantamine, donepezil, or rivastigmine, it can somewhat improve the memory in the first 6 months to a year. Sometimes I tell the patient that it can turn the clock back to a year ago or 6 months ago. But at the end, the patient still decline, right? For example, I give some example that this medication is acting like a Tylenol. If you have a fever, you take Tylenol, you stop the fever. It's a symptomatic treatment. But if you have fever from bacterial infection, you should take some antibiotics. And the antibiotics is the disease-modifying therapy. It's not the symptomatic treatment. So there has been a very long-standing effort to develop the amyloid-lowering agent. From the standing 20 years ago, we start with the active immunization that they induce have a mice models having like a injection with a vaccine and have the mice or the human producing the antibody. And what happened was like there are some people that are developing some kind of like meningoencephalitis because this is the immunogenicity, right? So people or mice or human produce the immune in order to attack amyloid. And that is why it's causing some inflammation of the brain. And some people die from it. But it is very interesting starting point because with this kind of study, we know that there is a chance that we can remove the amyloid plaque from the brain. It's not staying there and no way to remove it. So because after those, unfortunately, a couple of those patients died from this condition, and they had the brain autopsy and found that it's clear amyloid from the brain after the immunization. So now the concept changed to more passive immunization that inject with inject with the antibodies rather than having the humans producing antibody by itself. So there are many anti-amyloid therapy in the past that has like initially they thought that it's promising and then later on it's turned out to be negative outcome on many of those studies. But all of this study, all of this medication are mainly targeting on the molecule of the amyloid protein. But later on, we know that targeting on this small molecule is not any more effective. And targeting on the plaque or the larger molecules may be the next aim. So this is coming with not very successful, but aducanumab or aducam, right now it's not anymore in the market. I remember that the first day that I was treating the patients at 9 a.m. in the morning, patient come to me and say, hey, am I eligible for this medication? And I look at the Google and say, oh wow, FDA just approved this medication just 30 minutes ago. So I'm kind of not up to date comparing to the patient. But now, not anymore in the market because the results are so very controversial. This is the next one, lecanemab. This is another anti-amyloid therapy that have the study in recently approved by FDA like a year and a half ago with the traditional approval in July 2023. And the study originally, they recruit people who have MCI or mild dementia from Alzheimer's disease. And those need to be confirmed with amyloid PET scan or the CSF study for the Alzheimer. It's not only the clinical diagnosis, it needs to be biomarker confirmed. And it's only for MCI and mild dementia, not in people who have moderate or severe dementia. And the study is about 18 months, and they recruit about like 1,900 on the treatment arm and placebo arm, like 900 on each. And sorry, I confused about this one. Okay, so the MMSE in average is about 25. Wow, 25. It's very high, right? Normally, sometimes we use like 26 at the cutoff for dementia. 25 is still considered as quite high in people. So these kind of like participants in the study are very, very early. And majority of them are actually MCI, not even mild dementia. And the lowest cutoff that they use for the MMSE cutoff is like 22 from 30 point. They only use in people who have amnestic, it means memory predominant AD, not in people who have language, visual spatial, or motor predominant or frontal predominant AD. But it's only amnestic who come with the short-term memory changes. And the medication is biweekly. So the benefit, let me move to the next slide. Yes. So the study showed the benefit of 27% reduction of the rate of progression. If we convert 27% to like over the duration of the study of 1.5 years, to be simple to the patient, I usually say like it's 5 months delay the progression over 18 months of dementia. But the very important message that we need to tell the patient is this doesn't reverse. This doesn't make the memory better. It just delay, okay? Because both of the placebo and lecanemab arm, they still decline in terms of the cognition. This is for the overall study, but for some part of the subgroup analysis, it's found that if people have very low tau and very low amyloid burden from the PET scan, some of them might have a chance to improve after the treatment. The side effect of this medication is something quite serious and need to be cautious in terms of discussion to the patient. I say serious, it's not like that very fatal or causing a lot of death in patient, but it is something that patient need to be aware of. So one of the side effects is the reaction to the immunogenicity of the medication and cause the brain swelling and cause the brain to be bleeding. Okay, it's called area edema and area hemorrhage. And that is depending on the gene's carrier as well. That can stratify the risk of the side effect. The next one that approved by FDA like a year ago, 6-7 months ago, is called donanemab. And this is another type of anti-amyloid therapy that is mainly targeting on the plaque, the final pathway of the protein. And basically is running the same kind of like protocols to lecanemab. I don't want to go into much detail about this, but they need to be CSF positive or amyloid positive as well. But those patients need to be tau positive as well. They use a tau PET scan in order to recruit the participant, comparing to the lecanemab that they don't scan for the tau PET as a part of the eligibility criteria. It's the same 18 months, around the same number, around 1,700 participants with early symptomatic AD, MCI, or mild AD. The benefit is every 4 weeks infusion. So patient doesn't need to go every 2 weeks to the infusion center or be admitted to the hospital because this is 1 monthly. And the outcome is quite similar. That is delay the progression of cognitive decline. The number may be a little bit more impressive with like 35% slow rate of progression, but this is for people who have low to medium tau pathology. When combine everyone together, it's delay the progression about 29% of the CDR sum of boxes compared to lecanemab that is 27%. So it's very comparable. The side effect is higher, including the area E that occur like about 24% and area hemorrhage occur about 31% of the patient overall. Now the company, they start trying to adapt the way to give the dosage of the donanemab. Rather than having like a 700 milligram 3 times monthly and then one like a 1400 at the 4th month, they change a little bit in order to slowly titrate up the medications by starting with 350, 700, 1050, and 1400. And they found that the side effect like swelling and bleeding from the medication is significantly lower. And that is likely going to be potentially a new update on the label of this medication in the future. Unfortunately, those 2 medications is not yet approved in Thailand. Likely going to be coming soon. Who's going to be the good candidate for these medications? From the studies, is MCI or mild dementia. Those patients shouldn't have any neurological, medical, or psychiatric condition that can explain the cognitive impairment. They shouldn't have been taking anticoagulation like a blood thinner. Aspirin, Plavix is okay, but the blood thinner is contraindication. They should be able to get an MRI. If that patient have pacemaker or have any device that cannot do the MRI, they are not eligible for the study, for the medication. And they shouldn't have a lot of comorbidities like end-stage cancer, have mild Alzheimer, and want to come with this medication. That should be something that we need to discuss with the patient, that you are not likely gonna get the benefit from the medication. This is the side effect that everyone who consider to get this medication are worried about. It's called amyloid-related imaging abnormalities. One side, on the right side of the slide, is the swelling of the brain tissue. On the other side is the bleeding. The black dot here is the bleeding on the cortex or inside the brain parenchyma. So Even these are the side effects, but majority of the patient who develop this kind of side effect are asymptomatic. But some of them can have some serious complication from this. So this is an overview about what we have so far right now for the treatment of Alzheimer. And I would like to mention a little bit about a couple of trials that is ongoing right now in the US, in Europe, and including in Japan, that we know that lecanemab and donanemab are working in people who have mild cognitive impairment or mild dementia. But what about in people who don't have any cognitive impairment, but they just go for the screening of PET scan and have positive PET scan for Alzheimer without any cognitive impairment on the test? Those called pre-symptomatic Alzheimer disease. And they want to see how these two medications can delay the progression of dementia or the onset of MCI in those patients. So one study is called AHEAD study, and they have two sub-studies. It's called AHEAD 3 and AHEAD 4-5 study. That is for lecanemab. So look at this graph, like this one is already the indication for lecanemab in people who have MCI and dementia. But what about the preclinical AD who are still cognitively normal? They use the PET scan. This is another role of the PET scan in the clinical trials, that they use a PET scan to cut off the level of amyloid burden. If the patient have 20 to 40 centiloid of amyloid PET scan is considered as low burden, they recruit those patients into A3 study. And if the patient have more than 40 centiloid, they recruit those patients into like A4-5 study. And they want to see if this medication is working. So now they close the enrollment. Likely we're gonna have the result by 2028 and see if it's helpful. Trailblazer study, Alzheimer 3, is for donanemab. Basically quite the same thing that they use for people who have like normal cognition, and the primary outcome is to see if there's any worsening of the clinical dementia rating scale or not. Likely the result going to be available by next couple of years. The third one is lemternetug. This is not yet in the market. Is in the clinical trial phase 3 study. It's going to take a while before we know the result of this. But this is the same pharmaceutical company, Eli Lilly, who developed donanemab. They developed another generation of anti-amyloid therapy called remternetug, which that claimed to be lower swelling and bleeding side effect, and plus it can be a subcutaneous injection that patient can self-inject by themselves without any need to come to the hospital for the infusion. So the result is expected to be in the next 4 years, 2029. It's not the result, it's the primary completion. So they're gonna take a while to analyze the result and let us know. That is all my talk. Thank you for your attention.
Thank you. And after we hearing about the previous work and interesting lecture from our panelists, moving to the discussion part of this section. We have a couple of minutes for the discussion. I have plenty of questions to ask all speakers about the future of Alzheimer's disease, both for investigation and both for the treatment part. First, I want to ask Dr. Warapan about how could we implement the fluid biomarker for the upcoming aging society in the entire Southeastern Asia.
Well, the goal of using fluid biomarkers hopefully for screening and help early diagnosis. However, it's all will be impact on medical community and also budget burden of the government or individualized if the country ready or not for this impact of this early detection and this high cost, high technology use is something that you need to be consider and prepare for this impact, such as you can ask medical insurance, private insurance, whether they can help or not. However, the goal is to help for screening and early detection. It's not just like fasting blood sugar that you go and check. You need medical advice, counseling before performing blood tests. Some certain blood biomarkers, as I said, can use as disease monitoring like GFAP or NFL or even some other form of p-tau as well. And also some other tests can be used to look for other neuropathology in addition to Alzheimer's disease. Like Dr. Shanisa said, it's not pure Alzheimer's disease in every cases.
So Dr. Orapan mentioned that there may be a lot of things to concern about the medical expert to screen them first and also the cost and other things before the implementation. And I want to ask the opinion from Dr. Paranyu. Do you think that fluid biomarker could change the way of dementia practice in the near future, especially where the setting may be abundant like the metropolitan area or the private hospital setting?
Yes, definitely. I positively sure that the biomarker gonna change the way that we detect and treatment of dementia in the future. So amyloid PET scan definitely is very important. The fact is about the cost and the accessibility, right? In Thailand, we only have like a couple places that can do the amyloid PET scan. The CSF study is I wouldn't say it's a game changer, but it's very helpful for another way to detect Alzheimer protein in the brain. But it's come with the cost of more invasive testing and possible complication afterward, like the headache, those stuff. So that could be a little bit downside of the CSF study, but it's still very, very helpful because we use the CSF in order to treat the patient with Alzheimer with anti-amyloid therapy in the past as well, like before the amyloid PET scan approved by the government as and reimbursed. But I think in the next 4 or 5 years, or maybe shorter than that, is going to be a blood-based biomarker that Dr. Warapan is working on. Will be a big game changer in terms of the diagnosis of AD. Yes.
So both of the panelists also guarantee that blood biomarker may be implemented in the near future and it will be one of the game changer or evolve to become maybe one of the standard investigation, but we may have to recommend the real use for it. Okay, and we also know that fluid biomarker are developing further, but the PET scan is still the best method to measure the biomarker in the real time, like Dr. Shanisa said before the patient died. However, okay, the PET scan may have some drawbacks from the availability and also the difficulty in preparation. I want to ask Dr. Shanisa that how could we overcome this issue when there will be more cases that must be assessed with PET scan in the near future, especially some patients may be screened from the blood biomarker first and then they want to assure and go to perform the PET scan for the gold standard.
Okay, PET scan is very expensive, right? So there is no best solution now. It can be done by scheduling the day for the specified number of the patient to do the PET scan as a pool. For the hospital with PET in Bangkok, it's easy. In Bangkok or in the Sinaklin University in Khon Kaen, it's easy to supply the radioactive compound to that center. But the hospital with PET, located in the south, the north, or the Chiang Mai hospital. Is anyone from Chiang Mai or Songkhla Naklin? Is there? No? Okay, it's lucky because from the hospital with PET at the Chiang Mai University and at Songkhla Naklin University, we cannot supply the radioactive compound to them. It's a very far and the short half-life of radioactive compound. So just only one way, you need to send the patient to the Bangkok to do the PET scan. But in the future, we hope that we can teach or transfer the knowledge how to synthesize the radioactive compound. But if you choose this way, there is a lot of investment, a lot of the money to implement the cyclotron and to learn about the synthesis of the radioactive compound.
So one of the difficulty is the larger area may become more difficult because of the cost, the transportation, and also the preparation for the radio tracer. Okay, and I also want to discuss about the digital neuropsycho test. As we see, the people nowadays have their smartphone and digital tablets in everyday use, and like Dr. Warapan mentioned that they want to produce the digital test that can use at home. Is it possible to implement the digital screening test in household setting in real life situation?
I believe that we can. It is possible that why we try to have this web app with this simple digital psychological test. As I said, we have studied in our Thai population before that we use brain volume, we use a cognitive test, we use other more screening tests, and we found that these just simple tools in our cohort, in that cohort, is good, produce good accuracy. That's why we produce another cohort to test. We have tests in the north, in the south, and in the northeast, and in Bangkok, not our hospital, to get that result. Problem is some elderly doesn't get used to drag with these mobile telephones, so tablet would be better, larger face. But you can see that when you go to bank, nowadays they don't use paper, they use digital that you can sign and say yes, say no. So that everybody is now try to get better in terms of high technology. Even the government pay 10,000 baht through app. So everybody is trying to know at higher technology. So we believe that with a simple test, easy test, it would be possible in comparison to Camcock. It's more difficult.
So Dr. Warapan believes that because of the innovation of technology, every people, specifically the elders, also need to adapt themselves, and the household setting for the digital psychotest or digital cognitive game may be possible in the near future, right?
We hope that we can teach relatives so that they can guide and teach, make the elderly be more familiar with this application.
Okay, so I'm also find many physicians still prefer to use the paper and pencil test for the psychometric measurement. I want to hear some opinion from young generation like Dr. Paranyu, who also familiar with the test development. What do you think? How we should promote to induce more personnel to use the digital test?
So I think the computerized battery test is very, very helpful, very important. Training the staff to be able to help patients along the way of the test is very important. That can save the time that the clinician's gonna see the patient, because sometimes we have only like 30 minutes to see the patient, and if we need to spend like 20 minutes to do the memory testing, it's impossible to see the patient in the clinic. So I think training is very important for the staff, like other healthcare staff, to help with the test administration. This is very helpful for the screening as well. Like for example, you go to the primary physicians in the clinic, and then you have this test, and then if it's abnormal, you send the patient to like a more memory clinic or tertiary care. This is also very helpful. But I'm a little bit kind of like old school trained that we usually, as Dr. Warapan always teaching us when I was in the medical school as well, that we should rely mainly on the clinical symptoms, right? So like personally, I still like prefer, as you mentioned, that to use like paper pencil test when I see the patient in the clinic by myself, because that is not only how they meet or they fail the cutoff score, but what is the process that make them successfully doing the test or make them fail the test. So it's very helpful for the bedside evaluation and see how if that patient have any true cognitive problem or it's only from the trouble understanding of the test and instruction is not clear enough for them, or from the techniques that elderly doesn't know how to use those type of gadgets. So I think there are kind of like variations that we should take into consideration as well.
And apart from the digital test technology, from the PET part, are there any new technologies that will help nuclear medicine specialists using PET scan nowadays?
Okay. So for now, there is no big change about the technology. For the technology is about the PET scan, but it is the developing about the software. Example like the software that help the radiologist to read the PET scan. In the any uptake is really small uptake that can detect by the visual images. Another example like we call the AI morphometry. This is AI that can detect the brain volume from the MRI. From the our center, we have the preliminary result, accuracy between the AI and radiologist. We found that AI is better accuracy than radiologist. The AI is about 70% accuracy, but radiologist is about 60%. But not big difference, but the radiologist is not equal to the AI. Okay.
Okay. And because the time is coming, so I want to ask one last question before the Q&A part. I want to hear an opinion from the panelists because we have this conference from the Department of Medical Service, Ministry of Public Health. What do you want the Ministry of Public Health and Department of Medical Services to help handling dementia care and policy in the super age society in Thailand nowadays? I want to ask the opinion from Dr. Warapan first.
I've just heard that the government, your ministry, try to look at MCI. I think it's good to look at MCI, but MCI that we hope that you're looking at is MCI that's a risk for disease progression of neurodegenerative, not MCI just yesterday I have a flu. It's MCI because I failed the test. So what we need is perform early diagnosis, accurate diagnosis, disease staging is a correct and holistic approach using mild, moderate, severe, and using high technology or like robot or digital or sensor sensing device to help our patients safe and more mobile and more cheerful, more happy in the future.
Dr. Warapan want the process and also the instruction of both all of the investigation and also the new technology for the treatment. And what about Dr. Chanisa?
I'm the radiologist to do the PET scan. So I hope that the PET scan can reimburse or partially reimburse from the government. Yeah, because it's really expensive. Yeah.
So the co-payment may be an excellent answer for this condition. Yeah. And the last one for the young panelist, Dr. Paranyu.
All right. I'm not sure if I'm in a good position to suggest the department to do any change. I think like maybe not very possible, but ideally, as Dr. Chanisa said, like if the PET scan is reimbursable, even full reimbursable or partially reimbursable, that would be great. Medication, I'm not expect for that it's going to be reimbursed by the government. It's tough. It's not possible with the cost of the medication. But I'm thinking about more not focusing on just MCI and mild dementia, but we should focus on dementia at the spectrum of mild until severe. Moderate severe dementia, there's a lot of burden to the caregiver. There's a lot of behavioral issue that the patient can have. And I feel like sometimes the caregiver, the family, doesn't have the good hotline resources to connect. It's hard for them to call the doctor in the middle of the night or like during the weekend. And this is creating a lot of burden to them. I think like if the government or the Ministry of public health have some kind of like connection with the Alzheimer Association, have some funding from that, and creating some kind of like dementia support hotline for caregiver in people who have severe behavioral symptoms from dementia. That would be helpful and save a lot of time. And the holistic care, like training the therapy programs, like a physical therapy, occupational therapy, and speech therapy. We usually think about those rehabilitation as a part of stroke, post-stroke care, bone fracture, and have to go to the therapy. But the rehabilitation are very, very, very important in people with dementia. They fall, they have trouble swallowing, they have pneumonia, aspiration pneumonia, and die from sepsis. But the training in the level of the training for the therapists, I'm not sure how much that they emphasize on rehabilitation on neurodegenerative condition. I think that is another aspect to be more holistic approach for people with dementia, even not just mild dementia, but more advanced stage. Yes.
I also agree with the hotlines because my superior, Dr. Tassani, and also many superiors in the ministry also think about the ideas of hotline too. We have the hotline for the stroke in around Bangkok, but some superiors also want to implement the hotline for the dementia care. Also, maybe include some psychiatric condition too, to implement it for caregiver and also normal people to make a telephone call and consult the specialist or maybe some nurse care team to deal with this problem before going to the hospital. But I think in the future it may start in the future, and it's a good idea that we should develop in the near future.
Yeah, it's gonna help a lot in terms of preventing the unnecessary hospitalization. Like I have one patient that is admitted to the hospital right now that because they changed the environment, they come from home to be in the kind of like rehab center, and they become aggressive, and they need to be admitted to the hospital, which if we have the hotline and our trained nurses can guide them, and it's simple, it's improved with just low dosage of Seroquel and done. So patient doesn't need to be admitted, right? So that's helpful.
Thank you all the panelists for your discussion. Now we are in a Q&A session of this session. We have a couple of minutes that audience can bring us any question to our speakers. Please feel free to reach the microphone and ask some question. We have about 5 minutes or 10 minutes, maybe 1 to 2 questions to ask the panelists. Yeah.
Thank you for the amazing sessions. I have 2 questions. One is that, well, we are focusing on the pathological lesion. On the other hand, is there some other kind of imaging to study for the cognitive research, like objective assessment for cognitive research? And the second question is that maybe goes to Dr. Paranyu. How's your view on the GLP-1 receptor antagonist for like neurodegeneration? Yeah, thank you.
So the first question is she want to ask, apart from the brain image that will see the brain pathology, she want to know that there are any imaging modality that we can assess the cognitive reserve of the patient. I'm not sure about the cognitive reserve, like maybe the volumetric test or something like that. Maybe I want to ask Dr. Chanisa.
You mean the test, the brain imaging test is for the cognitive, right? Cognitive reserve. I'm not sure that the MRI volume can do the cognitive reserve, yeah. But the PET scan cannot do the cognitive reserve, but maybe the MRI, yeah. synapse, yeah, yes, the synapse, yes, the MRI synapse, yes, can do the cognitive research, yeah. Yes.
So the question about GLP receptor antagonists, honestly speaking, I'm not very familiar with this medication because it's not something that we use every day in the clinical practice. But the role of that to prevent dementia is still not very certain, including it's not very certain for the treatment of dementia for this medication. But I believe there might be some indirect effect of this medication to help with some vascular changes or some kind of like a metabolic profile. And then afterward, we know that vascular cognitive changes is one of the co-pathology of Alzheimer that can drive Alzheimer to progress faster. So if we have this medication to control the vascular risk factor and metabolic syndrome better, that might be an indirect effect to that. But I believe there's some study about that in terms of like Alzheimer prevention, but not very aware of the result available yet. Yes. I'm not sure if other speaker have any.
GLP-1, DPP-4, or something like that. Because I think there may be some study. I think that the question comes from there may be some study that from some DPP-4 inhibitor or GLP-1 agonist that have the outcome of a cognitive outcome after using these types of drugs. And she want to ask an opinion about what do you think or how can we implement this in the clinical scenario? Yeah, what yeah. What do you think from your perspective maybe?
Semaglutide, you mean? I think that's based on inflammation theory that they stop or decrease inflammation, like the person in diabetes with diabetes mellitus. The clinical trial that I don't know, probably they have in your country. What they approach in Thailand is just those with mild fasciitis, white matter lesion, just one. But my boss, Philip Shelton, said it's in Europe. They also have a study those with fasciitis score of 3. But they don't allow us to use because I think they're afraid of side effect or something. But they don't decide to have launched the clinical trial in Thailand. I don't know. But those are based on inflammation. Mm-hmm.
Okay, we can have another question, another quiz question. Okay. Okay, so if we don't have another question, I think we can finish this session because every panelist and every audience can go to travel and see a lot of sightseeing areas within Thailand too, and they can enjoy the travel, they can enjoy their favorite food, and they can enjoy a lot of experience in Bangkok today. Okay. Thanks to all the audience who stay with us through the end of this talk, and thanks to all the panelists within this stage. Thank you for joining us today, and hope everyone has a safe trip back to your homes and your accommodation. Thank you very much.
So thank you very much, Dr. Jesda, and also our panelists. This session is very informative. And before we go home or traveling, I would like to say some information for reminder you for tomorrow. Our session, international session, will be at this room again, and it will start at 9 o'clock. And so we look forward to welcoming you to tomorrow. Thank you. ถ่ายรูปไหมคะถ่ายเรียบร้อยค่ะ